Well, good afternoon. We're going to go ahead and get started. So my name is Wendy Ellis, and I'm a doctoral student here at George Washington University. I run the building, I'm the project director for the Building Community Resilience Collaborative, which I'll tell you about in a moment. But I want to introduce our panel here to discuss clinical approaches to trauma in here in Washington, D.C. The first panelist that you'll hear from after my presentation is Dr. Daniel Newman, who is a pediatrician in the Department of Community Pediatrics in Children's National Health System. He is the Associate Medical Director and practices clinical medicine at the Children's Health Centers at Adams Morgan and Shaw. He is a co-chair of the D.C. chapter of the American Academy of Pediatrics Immigrant Child Health Committee. His interests include working with immigrant children and families, as well as teaching the next generation of physicians. Besides patient care, he also plays a role in pediatric resident and medical student education. He attended medical school at New York Medical College and then completed his residency training in pediatrics at Children's National in 2012. Our second panelist will be Jenny Crawford, and she is the Integrated Behavioral Health Director at CCI Health and Wellness Services. Jenny supervises the behavioral health treatment staff and as part of CCI's senior leadership team, works to integrate mental health and substance abuse services into primary care at CCI's locations for a population of 26,000 medical patients. Under Ms. Crawford's leadership, substance abuse and depression screening is now included in medical appointments for all adolescents and adults. She is also leading a journey for CCI to become a trauma-informed organization with initial trauma screening focus on youth with obesity or asthma. And our third panelist is Rachel Osborn, who is a clinical manager for Mary Center's school-based mental health program. She specializes in partnering with youth and their families to provide comprehensive mental health care in the school setting. To this end, she also provides workshops, consultations, and clinical supervision to support the development of trauma-informed education and clinical practice. So what we're going to do is I'll start with a short overview of ACEs and trauma to kind of give us a level set, and then our panelists will come up and we'll save Q&A for the end. So I want to start by explaining, I know we've talked about trauma in this morning's sessions, we've talked about adversity, but I want to kind of give us more of a definite definition around that. So adverse childhood experience is this term that's given to describe all types of abuse, neglect, and traumatic experiences that occur to individuals under the age of 18. The landmark Kaiser ACE study examined the relationship between these experiences in childhood and health and well-being later in life. The ACE study looked at three categories of adverse experiences. Those include childhood abuse, which included emotional, physical, and sexual abuse, neglect, including both physical and emotional neglect, and household abuse, which can include growing up in a household where there was substance abuse, mental illness, violent treatment of a parent, parental separation or divorce, or had a family member who had been incarcerated. The prevalence of ACEs in America has only increased since that first study in 1995. The science behind early traumatic experiences, such as these, help us to understand the influence of community environments to either buffer or exacerbate adverse experiences. So as we grow to learn more about the physical, mental, and physiological effects of adverse childhood experiences, it is apparent that we must examine them within the context of the community. For instance, the effects of a parent's substance abuse multiplied by the effect of community environments with inadequate access to resources such as healthy foods, quality education, steady employment, can have a devastating effect well into adulthood. In other words, adverse childhood experiences are like the leaves on the street. They are the outward symptoms of a community
we chose to focus
planted in poor soil. The roots on this tree fail to thrive in soil that is steeped in concentrated poverty, inequities in economic development, community violence, racism, and lack of affordable housing. In other words, many ACEs that we observe are directly associated with the vitality of the community environment. So when combined, adverse childhood experiences and adverse community experiences result in complex trauma that is felt at both the individual and the population level. The persistent exposure to adversity experienced by both children and adults without adequate family and other social supports has come to be defined as toxic stress. Toxic stress is unrelenting. It's not merely the stress associated with having a bad day at work or an argument with your spouse or the airline losing your luggage. Because in those examples, it's unlikely that you are also similarly worried about where your next meal is coming from, where you're going to sleep that night, and or even worried about being shot when you leave your home. So when individuals are facing regular stress and meeting the necessities of daily living, it is similar to being in a constant state of fight or flight. This results in overactivation of the body's stress axis, increased heart rate, rapid breathing, sweating, anxiety, of which we heard a lot about this morning. This chronic stress with little to no buffers can result in physical, psychological, and neurological damage. In fact, the latest neuroscience that we are seeing shows us that this type of stress in young children actually changes the brain architecture.
And also the Maryland Healthy Eating and Physical Activity Act has a similar...
So what we have found that there's a graded relationship between the complex trauma of adverse childhood experiences and subsequent health problems in adulthood, and it's well established. The more stress is endured in childhood, the more likelihood of developing heart disease, obesity, depression, diabetes, even risky sexual behaviors. So as referenced in my earlier slide, adverse community factors are the root cause of outcomes such as homelessness, violence, economic hardship due to under or unemployment, resulting in areas with low stock and affordable housing, limited economic development with failing schools, public safety issues, and inadequate access to public transportation. These data come from the Center for the Child and Adolescent Health Measurement Initiative, and these survey responses indicate that 1/4 of children here in DC have 2 or more ACEs, a proportion that is well above the national average. So these ACEs include those from the traditional categories, such as incarceration of a household member, separation and divorce, mental illness in the home, substance abuse in the home, and domestic violence. But what these data do not reflect are the ACEs that we've been discussing this morning, those that are unique to our newly arrived populations. Those traumas associated with separations of families due to immigration policies, adverse experiences that may have been suffered in the process of migration, whether that be documented or, authorized or unauthorized. There's also a growing awareness of the traumas associated with acculturation. These are the issues that require a trauma-informed approach. On the right, you can see the prevalence of ACEs, regardless of immigration status, and DC's adult population is nearly evenly split amongst the races. This slide gives you an idea of the types of ACEs that are prevalent in DC. I draw your attention to the circled areas where we see extreme economic hardship, witnessing neighborhood violence and domestic violence, having a parent incarcerated, or worse, the death of a parent. In all of these categories, DC is well above the national average. In fact, nearly double the average in witnessing neighborhood violence. These categories speak to the need for a multi-sector strategy of prevention. While ACEs are a public health threat, many of the solutions to address community violence and the outcomes associated with extreme poverty require cooperation across multiple government agencies and private community organizations. The science of resilience shows us that while exposure to ACEs can be devastating, it is possible to not just bounce back, but also bounce forward. First and foremost, for children, this resilience is informed by the social supports that are available to their families. The first line of defense that can provide buffers from an adverse experience. So think about resilience in a nested model. A child's resilience reflects their family's resilience, which is informed by their collective access to community supports and resources. So as this graphic suggests, community, family, and a child's resilience is nurtured in a protective home environment with access to quality health and education, as well as social and economic resources. I just want to draw your attention to fact number 3. Among kids with ACEs, those who do not have a family-centered medical home are 41% less likely to be engaged in school, 55% more likely to repeat a grade, and 41% less likely to exhibit resilience. Remember those numbers in the context of the fact that I gave you earlier. 1/4 of our children here in Washington, D.C. have 2 or more ACEs. That numbers reflect 1/4 of our children here in this district. So let's talk about the context for systems response. What do we do? I've depressed you enough. Let's look it up a little bit. So responding to the need to prevent the effects of and address the factors associated with the pair of ACEs comes in the context of healthcare reform, which provides an opportunity to rethink healthcare delivery and partnerships across sectors. So this is all occurring right now where we have limited access to mental health care, behavioral health care for kids, fragmented services. Anyone in this room who's ever tried to refer a child to or a family from a medical environment to a social service agency knows that we're all disconnected. This is all occurring while we have an increasing number of ACEs, an increasing number of children living in poverty, while at the same time, there's this increased dialogue going on around social determinants and an upstream approach to healthcare, which then leads us to understanding that we have to somehow bridge our clinical environments with our community environments. But the barrier is how to get there. How do we translate the evidence that we know with regard to social determinant impact on health into real practice and policy change? So here at Washington, at Milken Institute, we're testing a model that I conceived called Building Community Resilience. And it's based on all of the evidence that I just gave you. That we understand what the connection is between adverse childhood experiences and adverse community environments, and yet we've not been able to do anything, actually put it into action, and empower physicians as well as community to work together. And so this model is being tested in 5 cities to help health systems work with community agencies and city governments to really be more actionable from a prevention standpoint. So it's establishing a shared understanding. What I just did here, we set a level set, talking about ACEs and toxic stress, things that are very particular to our communities. An example of some of the town halls we've done in some of the cities. Assessing our state of readiness. What do our systems look like? What is our provider capability? And what are the training needs? And starting from a strengths-based position of looking at what are the policy supports that we can build off of. Bringing those cross-sector partners to the table to figure out where are our assets, what can be leveraged in response, and what kind of community and political partnerships can be built. And then making sure that we have engaged families and community that help to co-create these solutions. This is not meant to be stepwise, but rather this is continuous. So we're working in all 4 of those areas at the same time. So building community resilience is in 5 cities across the country: Cincinnati, Dallas, Portland, Wilmington, Delaware, and here in Washington, D.C., we're working with Children's National, the D.C. Academy of Pediatrics chapter, MedStar, Georgetown University Hospital, and Unity Healthcare. The work that we're doing that you'll begin to see as we roll out over the course of the next year is we've developed a physician resource toolkit to help physicians think about how do I screen for ACEs, how do I enter into that conversation, and then what do I do? How do I connect? Who does the connection to much needed resources for our families? Georgetown MedStar University Hospital and Children's National have developed have started the Early Childhood Innovation Network, which we'll see a few pilots that they're going to roll out in the next coming, I think it's 6 months, on really early intervention in the birth to 3, prevention of ACEs. We're doing coalition building, bringing the grassroots level into the conversation. If we are going to have impact, those voices from the community have to be a part of the solution. And then the Bainham Family Foundation out of Bethesda, Maryland, has funded 13 organizations here in DC, including Children's National and the ESA Network, and the Birth to 3 Policy Alliance. So not only changing practice, informing practice, but also informing policy at the same time. So with BCR, what we've done is we provide monthly learning sessions for all of our sites. So it's a peer-to-peer learning network. We have a virtual team space where individuals are sharing information. We provide experts and technical assistance out of GW here. Strategic convenings, we bring the teams together, but we also help them have that dialogue in community. And then we provide a communications and policy platform. But what's most important on top of all the action on the ground is the golden rule: what gets measured is what gets done. And so data is a very key part of this. And we've actually launched a data dashboard to help to begin to measure what is our commitment to health equity, how does that translate into actual action. Translating the theory behind ACEs into practice, understanding how well we're doing on referrals and coordination, the resilience and strengths programming, as well as measuring stakeholder engagement. And most importantly, making sure that we find a financially sustainable way to maintain this work in all of our communities. So if you want to learn some more information, I'm right upstairs on the 3rd floor, there's my email. But I want to now turn it over to Dr. Newman.
Thank you, Wendy. That was a great foundation for what we're going to be talking about today. And I'm primarily a pediatrician, but I also have a role in the American Academy of Pediatrics in the local DC chapter. And I'm going to talk to you a little bit about what I'm doing in that role with the American Academy of Pediatrics. Very popular theme about ACEs and toxic stress in the world of pediatrics. This is from a couple weeks ago, but the past president of the national AAP spoke at a congressional briefing about toxic stress and ACEs and the importance of policies to help family resilience. And so what we're talking about today is very timely in the world of healthcare and very important topic. So like I said, I'm a pediatrician, so I'm going to give you all kind of a case scenario. This is what we do every day. So it's a busy day in your office. You see 11 patients in a half day, so number 9 of your 11 patients in the morning. And remember, you have about 20 minutes per patient on your schedule. And it's a new patient. His name is Diego. You're already running about 30 minutes late because you had 2 previous patients that were complicated. And you don't really know what you're going to walk into. And you open the exam room door, and you learn a little bit about Diego. So he's here with his aunt. She was not even in the room. She's actually in the weight room, so it's just him. He's only Spanish speaking. He just turned 16 years old, and when you get a little bit more background, he just came to the DC area. He's from El Salvador, and he's now living with his maternal aunt who has her own kids, and they are regular patients, so that's his entry point into learning about us. And when I ask him why he's here, he says, well, I'm just here to get checked out, so not too much information to go in. This is obviously it's not his name, but this is a real case scenario. And unfortunately, we don't have to go too far back to find cases like this because they're happening every day in our health centers. But a little bit more about Diego. So he was living with his parents in La Union, El Salvador. He was in high school until this past May. His father was killed, and obviously I had just met him. He wasn't going to give me all the details, but he did disclose that, and he fled to the U.S. out of fear for his life. He hired a coyote and was smuggled through Central America to the U.S. border. His trip took about 14 days by car, bus, and foot. I've heard stories of much longer trips, more harrowing trips than that, so relatively speaking, it was fairly uneventful. When he crossed the border, he spent about 3 months. He was detained and spent about 3 months in a detention center facility in Texas under the care of the Office of Refugee Resettlement. And ultimately, they found his aunt, who was living in D.C., and reunified with her and was now living in the D.C. area. And he hadn't really seen his aunt in 10 years since she came to the U.S. So getting a little bit more history. So, I was trying to get some contact information because we were doing some lab tests that day. I asked him what phone number I could call. He was too anxious to have a cell phone because he thought it could be traceable, and he was too worried to have something that people might be able to track. He appeared very anxious in the room. He said he was having anxiety, which is fairly obvious. And getting a little bit more of the story, it seemed he was having some pretty substantial PTSD symptoms. He did get a little bit of brief medical care while he was in the detention center in Texas, but he didn't have any medical records, so there was a big question mark. Did he get vaccinated? Did he have a PPD? Any other testing done? He was prescribed a medication for anxiety that he took for a short while. He couldn't tell me the name. He ran out of it, wasn't sure what was going on with that. And then a little bit of icing on the cake, he actually had some significant past medical history that we couldn't really know anything about because all he could tell us is that he had some skin cancer. It was surgically removed, and we had no other details of that. So that took 17 minutes. Remember, your visits are 20 minutes long. You're already in your lunch break. You have 2 more patients who are kind of pacing the hallways waiting to be seen. And you feel like you've done nothing except to hear a little bit about Diego's harrowing story and take into account this is a detailed life record because I'm sure he's keeping a lot back at that first visit. So what makes Diego and other recently arrived immigrants' children unique? Well, they have very distinct needs, and we've talked a lot about that today, but all these needs are usually typically in the setting of ongoing poverty, which makes their needs even more unique. And when we talk about unique needs, I'm talking about not just clinical needs and medical and dental, but mental health. We talked a lot about legal needs and education rights and options and kind of knowledge base in that. So I just want to go through a few things that make these patients and children very unique to us. But a lot of them are coming in with unchecked chronic diseases. And what I mean by that is that things that we wouldn't typically see progress to the level of kind of uncheckedness that it comes into the door. So things like asthma, diabetes, like his situation of skin cancer that should have been receiving kind of continual follow-up care. And then you also have on top of that acute problems from travels or other acute illnesses that can happen. The idea of tuberculosis screening, other infectious disease risk, immunization status. So you have a 16-year-old young adult who comes into your office and you're not sure if they've ever gotten vaccines in their life, and you can assume that in El Salvador they do primary vaccines, but if you don't have any documentation of it, there's always a big question mark there. And then this is all in the context of a level of health literacy, which is very different from perhaps our expectations of what is normal here. So you could have a patient who has never seen a primary care physician before, who's only gotten some medical care when they get sick. So the whole idea of a routine, well child examination or a routine physical is foreign to them. So trying to explain the care system, which is confusing for me, let alone someone who doesn't know the system at all. Obviously, very distinct mental health needs. We've talked a bit about that today. It's been a theme of our discussions here, but people are coming with traumatic past life experiences. They have traumatic travel experiences. These kids have been separated and then reunified with family members, sometimes family members they don't even know. There's this overlying fear of deportation for themselves or for other family members if they themselves are in a safe situation. There's this whole idea of acculturation into a new society, language differences, there are new schools, a new group of peers, and so all of this is very kind of taxing in terms of mental health needs, and I would argue very distinct for this population as well. So some of the challenges that are faced there are, first of all, do we even have a validated mental health screening tool? We, in our office flow and in many other health centers around, in the past few years, we've been doing standardized mental health screening because we realized that as a group of physicians, we're not very good at picking up things unless it is kind of a regimented way of doing things. And we often overlook things if it's not kind of part of our mode of operation. So do we even have validated screening tools that are effective for this group? And then if we identify problems, are there mental health services for these children? Are there language appropriate mental health services? How do we connect families to these services? Is there a stigma on mental health that is a barrier? Are there problems with trust and belief in the mental health services? And then after all that, are you even finding the right people in the mental health service world that are trained in trauma-informed care? So this has been a big challenge, and you can imagine that the great demand that a lot of these kids walk in the doors with that we do our best to meet, but oftentimes it's fairly limited what there is to offer. We talked about this in the morning, but so everyone should know the answer to this, and actually the answer was supposed to come up next, but it's a giveaway here. So is a U.S. citizen, even known felon, given the right to legal counsel in a court proceeding? Yes, it's called the Sixth Amendment, the right to legal counsel. What about non-criminal immigration removal proceedings? No one's entitled to legal counsel. And this sounds crazy, but what about a 5-year-old immigrant child who was abused in their home country and is in a court proceeding for their immigration status? They're not entitled to legal counsel, and that is insane to say out loud, but it's true, and it happens. I think some more recent data has been presented today, but this is from 2014, study by Syracuse University looking at the total number of filed immigration cases in court for juvenile cases, and you can see that there has been a sharp number of increase in the filed number of cases, and when you extend that to 2015 and 16, it's gone up even more. And the gist of it is that most of these cases are pending for years. So you can imagine, going back to the mental health trauma of these pending immigration hearings, just the unknown uncertainty of what's going to happen in the future. This is a little bit outdated again, but the gist of it is exactly true today as it was in 2014 when this was published. But minors have legal representation in less than half of immigrant hearing cases. And when you look at the disparity between represented minors and minors without attorneys, the rates of deportation are quite staggeringly different, and successfully attaining asylum status or special juvenile immigration status are very disparate. And so this is absolutely key to kind of overall comprehensive care of these children, to get them linked up with legal services. So for clinical care providers, for pediatricians, for family practitioners, for nurse practitioners, is there or are there evidence-based approaches to caring for these immigrant children? And the answer, surprisingly, and 10 years ago I would have thought an obvious yes, that someone would have compiled some evidence-based guidelines and best practices, but the answer is not really. There's certainly some efforts to do that, and the American Academy of Pediatrics put out a policy statement in 2013. There's a couple other nice review articles. We can extrapolate some information from the CDC guidelines with refugees, but and you could argue that a lot of these kids are in fact refugees. I actually met my first patient who was given refugee status in Honduras before he left the country, which is few and far between, but does that really fit the demographic that we're working with to call them refugees? And I think you could argue either way. And there's some guidelines that are pretty well set for international adoptees, and you could argue that a lot of these kids who potentially come unaccompanied, you could fit them in the same realm as an adoptee, just having that kind of lack of information about background, medical history, etc. But the point is that there aren't really great guidelines, and you can imagine that as a medical provider, when you're rushing through your day to do your best job, that you really need some sort of structured, organized best practice guidelines. And there's some obvious reasons why, and I would say that obviously our patients deserve quality care, and their needs might be very particular and nuanced, which we just talked about. So there's also a pretty generalized lack of knowledge and awareness about these recent arrived immigrants. And I'd say For those of us who work in a setting where we do this every day, yes, we've gotten a little bit more experienced and kind of self-taught some of this, but certainly for places that aren't accustomed to see this population, people are walking through the door and people have no idea what to do and how to take care of these children. There's a great kind of unequalness of community resources and supports. Certain groups are linked in, other people don't know how to access those. Generally speaking, there's a lack of training and support in this realm, and a lot of people, like I said, have little experience working with this population. And each setting is different, so you might work in a healthcare center that has access to a co-located mental health provider, or a social worker that's 2 doors down from you, and that's very convenient, but not everyone has those options, and so there's great variability at each site. So a couple of years ago, the National American Academy of Pediatrics put together an Immigrant Child Health Toolkit, and it's online, anyone can go on and look at it. What a bunch of us locally have found is that it's not quite effective as a resource to use in the setting of your daily practice as a clinician. And so we actually, a couple of years ago in 2013, got together, and myself and a few other pediatricians in different healthcare centers that were essentially doing the same thing day to day. And we said, you know, we're doing things differently, we're taking care of literally the same patients because a lot of our families bounce back and forth between healthcare centers and the neighborhood. We should really sit down and figure out the best way to do this and the most effective way to do this. And so in 2013, we got together and formed what we call the Immigrant Child Health Committee, which is a little subgroup of our local chapter of the American Academy of Pediatrics. And right now we have members who are pediatricians, family practitioners, lawyers, mental health professionals, and a few other regulars who meet on a monthly basis and discuss issues that are pertinent to this population. The local chapter in DC of the American Academy of Pediatrics has about 450 physicians, doctors in training, and other members affiliate. And so it's a great access point to kind of disseminate out information, which is what we're hoping to do. So I want to tell you a little bit about a project we've been working on for the past few years. Ultimately, our goal is to create a comprehensive guide for medical care providers, and it's not just to be out there on the website, but something people can actually use in the flow of their clinical visit with a recently arrived immigrant child. And so we applied for a grant through the Healthy People 2020 program, the American Academy of Pediatrics, and in 2015 we were awarded the grant. And essentially we've been working to design this website-based toolkit to share hopefully in the next 2 months or so. We've got a beta version right now that we're just putting the content in, and it actually is looking fairly nice in terms of a layout and design. We had a very nice collaboration with a group called Design for America, which helped us kind of do some end user interviewing and guide some content and formatting needs. And so ultimately the topics that we intend to cover with this toolkit for providers of kind of evidence-based recommendations and resources are clinical care guidelines, resources about education and education rights, mental health services, social services resources, and a lot of what we talked about today is linking people up to the right services and resources, immigration legal services and best practices, access to public benefits in DC, and then language service and rights in DC access. So those will all be kind of subsections of this toolkit for providers to use. And ultimately, we want this to be practical for care providers. So everything that's been published up to this date has, there's content there, but it's not really practical to use in a rushed 20-minute visit. So we want something that's usable during a visit or as a reference resource for further education around a particular patient or issue. Initially, our idea right now is to start narrow and expand. So we, right now in mind have it to be catered towards primary care medical providers, but ultimately our goal is to share this with the rest of the American Academy of Pediatrics on a national level, and our more kind of broader goal is to share it with all of you who work in different healthcare settings or government locations or the school system, community centers, etc., to be used as a tool and a resource for families that you are seeing as well. So I'm happy to answer questions afterwards, but pass it on to Jenny.
Good afternoon. So I'm Jenny Crawford, and as Wendy said, I'm the Behavioral Health Director at a community health center that serves our entire community throughout Montgomery County and the northern third of Prince George's County. And we have primarily primary care, but also dental and behavioral health. And I just want to echo what Wendy said, but I was impressed that Dr. Robert Block, the former president of AAP, had said that adverse childhood experiences are the single greatest unaddressed public health threat facing our nation today. I think that's quite a wake-up call for us all to pay attention to. So we're focusing our initiative right now at looking at a connection between ACEs in children and asthma. So some of our pediatricians began to learn about this at our Tacoma Park location. And our Tacoma Park location is heavily Latino, 30 to 35% undocumented, uninsured, and we see just a tremendous amount of trauma, the kind of stories that you've been hearing about, fear and anxiety, trauma in home countries, trauma in the journey here, and trauma here that has really impacted our children. So our pediatricians were interested in the connection about our high rates of asthma and possibly the trauma that the children had experienced. So this just gives you a little bit of a demographic. Our systems don't make this as granular as we would like it to be, but we serve over about 6,600 patients at the Tacoma Park site, and 79% are Spanish speaking. Almost all of our staff are bilingual English-Spanish as well. So the connection between trauma and ACEs is a physiological connection. There's more and more being written about this. That ACEs lead to a chronic physiological change. And you can imagine kind of elevated cortisol. And so that if you're on high alert all the time or in a situation where you've got adrenaline coming all the time, that for some folks it can release these inflammatory mediators that are markers that are elevated during an asthma attack. And Dr. Newman would know more about the physiology of this than I do as a social worker, but it is a change that makes it difficult to be able to breathe appropriately and can lead to these airways narrowing and hyper-responsive airways over time. So there are a couple studies that really show this connection. This was a huge study of over 92,000 children ages 0 to 17. And 31% of those children have been exposed to at least one ACE. And I just want to clarify, when we talk about one ACE, we're not talking about one time seeing domestic violence. If you saw that, that's one ACE. If you saw 10 incidents of domestic violence, that's still one ACE. So we're talking about categories of adverse events. And among children with 5 ACEs or more, 25% had asthma as opposed to 12% of those with no ACE. So the conclusion was that there's an association between more ACEs and an increased likelihood of asthma. And then Detroit has the highest rate of asthma among children in the United States. And Johns Hopkins School of Public Health did a study which again showed this connection between ACEs and trauma regardless of what the environmental impact is. We know that there are environmental triggers as well in terms of air quality and allergens and other contributing factors. A study that I saw that I don't have in here showed that Hispanic children with 2 or more ACEs are 4 times more likely to have asthma than non-Hispanic white children. So when our pediatricians got excited, as the behavioral health director, if a pediatrician or a doctor gets excited about something that's related to behavioral health, I get really excited. So we had inspired, excited leaders who wanted to look at this. We looked at our data and our resources. We started small. I'm hoping that we'll begin to screen all children for ACEs, but we started with this group of children with asthma. We've developed workflows, outcomes, and we're working on our data collection. And we went and trained all of our staff about this and what it meant. And one of the things we used for training that I love, and if you haven't, how many of you have seen the TED Talk by Nadine Burke-Harris? So some of you. And so what I say in my passionate way is, if you have 5 minutes or whatever it is, 17 minutes, go home tonight and Google Nadine Burke-Harris and trauma. I think it's one of the most effective TED Talks I've ever seen, and it really lays out exactly what we're talking about. So we trained all of our staff, including our front desk, our medical assistants, our medical providers, and we promised to share what we learned. So we're just getting started in this, but I'm going to show you what we're doing that involves screening and treatment that we've begun to implement. So this is Nadine Burke-Harris's organization. It's the Center for Youth Wellness, and we've all kind of become gurus. And I figured, why recreate the wheel if we can take something and implement it that we think will work well. So this is their website. It's in San Francisco, and they're doing a lot with pediatric medical care and trauma. And this is our workflow. And I won't take you through all this because workflows can put everybody to sleep, particularly after lunch. But we did go to the website, the Center for Youth Wellness, and we lifted their workflow, which they have to share on their website. You have to register, and then you can access it. And most of it applied very nicely to our current workflows in our health setting, so that we're screening for trauma, all children ages 6 to 17, using the screening tools that which have all the ACEs questions and some additional questions. And so parents do the questionnaire for ages 6 to 11 when they're in the waiting room. Parents and teenagers do separately the questionnaires, and we do find the differences. Teenagers tend to rate their number of ACEs more highly than their parents do. I don't know why yet. And then the clipboard's returned to the medical assistant, and is scored. The number of ACEs that they reveal are scored and shared with the medical provider. If the medical provider sees that there are 4 or more, the family is invited to meet with our behavioral health staff at that site, who is trying to be culturally sensitive to all of our populations and is bilingual in Spanish and English. This is our screener. So these are all the regular ACE questions, and then we have from the Center for Youth Wellness some additional questions that they decided to include. We couldn't. Have you been in foster care? Have you experienced harassment or bullying at school? Have you lived with a parent or guardian who died? Have you been separated from your primary caregiver through deportation or immigration? Which I think is a really important question for us to look at in this next evolution of looking at ACEs. Have you seen or heard violence in the neighborhood or in your school neighborhood? Have you been detained, arrested, or incarcerated? Have you been treated badly because of race, sexual orientation, place of birth, disability, or religion? And have you experienced verbal or physical abuse or threats from a romantic partner, for example, boyfriend or girlfriend? So the nice thing about this, sitting in the waiting room, the family doesn't have to come in and tell their medical provider, who may be new to them, which of these bad things happened to them, just how many. So they count them up and they put them in the box. And that way we already know that they may be at risk for all the kinds of chronic health issues that Wendy talked about at the beginning. And over time, if they meet with the behavioral health consultants in our team, we can begin to unveil what those bad things are that may have happened to the child or family. So we also needed a methodology to look at the acuity of asthma, so that we know for intervening with mental health services, is the asthma getting better? And this is where we're still in a learning cycle. So there are these 4, components, I'm told by our pediatricians, about looking at asthma control, severity, what they're prescribed, if it's a steroid or, you have to pronounce this for me, leukotriene modifier. And so we're looking at assigning a number to each of these, so we can then have a number that would lead up to the severity of the asthma at the time. Our providers have been kind of all over the place in terms of how they document sometimes that severity in our charts, so we're trying to get a little more streamlined with this. So as of June, we've screened 83 children and adolescents for trauma, 43 children who just got the child assessment, 40 teenagers. We get both the parent assessment and the child assessment. 8 were referred to behavioral health. So because they had a score of 4 to 12. And then patients with 1 to 3 ACEs did 39. And the pediatricians carry a laminated card with symptoms. And they also are looking, even if it's less than 4 ACEs, they're looking to see if that child has symptoms. And they're doing some anticipatory guidance with the parents, saying, you know, I can see that some bad things happen to you. Thank you for sharing this information. In the future, if your child develops any of these kind of symptoms, please come back to me and we'll talk about that. But it begins to set the stage if there are behavioral issues, you know, anxiety, bedwetting, other kinds of things that could happen, that the pediatrician is a safe person to come back and discuss this with. So quickly, we have a story, a 15-year-old Latina girl who had 10 ACEs, severe depression. We do screen all children and adolescents for depression using a depression screener that's often used in community health centers called a PHQ. And it ranges from 0 to 27, 27 being severe. So she had pretty severe depression. Her asthma in 2014 was documented as asthma with acute exacerbation. Her father had been deported. Her brother was a violent alcoholic and violent to her and her mother. She'd been sexually abused at age 9. She'd witnessed a lot of violence. And today, and after 8 months of trauma-focused cognitive behavioral therapy, which is what we're using as our mental health intervention, her asthma is mild, persistent, but well controlled. Her depression score has dropped to 7, which is just low mild. Not as we'd like it to be under 5, but we've made a lot of progress. And this is the intervention that we've trained our staff to use. So it's an evidence-based treatment. It's structured, short-term. It's been shown to improve trauma-related outcomes in 8 to 25 sessions. And it addresses trauma such as PTSD, depression, anxiety, cognitive and behavioral problems. This is, you'll get the site if you want to look at this. And you can get a lot of information from that training site. And so it goes over the psychoeducation of what is trauma, how does it impact the body, how to self-soothe, how to manage your anxiety, how to deal with interpersonal relationships with other people, how to express yourself appropriately, how to think through problems and make good decisions. And when adolescents and children are ready, they can create a trauma narrative, which is the telling of their story in their own words as they remember it and how it's impacted them. So our conclusions are that adverse childhood experiences do create stress and anxiety. They can create chronic inflammation and increase the risk of asthma. We think it's important to talk about the psychosocial factors in the trauma history when treating asthma. That asthma has to be fought on multiple fronts, you know, from a medical perspective as well as this. Not everybody with asthma has a trauma background, but we won't know unless we screen. And that providing treatment for past and current traumatic events, especially if the child is demonstrating mental health symptoms, is really an important piece of the work. We're blessed to be able to have behavioral health on site. All our medical providers have to do is, you know, grab the behavioral health person and say, come into the exam room to introduce the family to somebody I'd like to meet. They get to move on to their next patient in the next exam room, and our behavioral health staff take over at that point. These are resources, and this ACEs Too High is a really great site, and they continue to update it with current information. And that's the site for the TED Talk that I mentioned. Thank you.
Good afternoon. My name is Rachel Osborn. I am here with Mary Center. Is anyone in the room familiar with Mary Center? Okay. Our youth expert, Daisy, gave us a shout out earlier. I'm here with our school-based mental health program. So I will be speaking to you a little bit about both the clinical and programmatic aspects of our work to decrease access barriers to mental health services for immigrant kids and families in DC. So, Mary Center, we've been around since the late 80s. We became a federally qualified health center in 2005, which really reinforced the work we were already doing to focus on providing services to vulnerable, marginalized, underserved, non-English speaking children and families in DC. And when we became a FQHC, this just furthered that focus. But when we began in the late 80s, we started by providing services to women fleeing violence in Central America. And our founder, Brie Gomez, who was a registered nurse, quickly realized that these women needed much more than just prenatal or postnatal care, which is typically what brought them in the door. So through that, Mary Center evolved into what I think makes us fairly unique as a healthcare provider, and that we operate on a social change model, meaning that beyond just medical care, we provide education and social services, and I found that it's really at the intersection of these three domains, when families have access to all three of these things, that they're really in their optimal place to be able to not just survive, but to thrive. I won't go through all of these, that would take the full 15 minutes, but this is an overview of the services that we provide in each of those three domains. And of note is that any single one of these services can be an individual's access point into Mary Center, meaning somebody's first point of contact might be with a doctor, a therapist, a case manager, a teacher, a after-school program worker, and we found that by equipping anybody who interfaces with clients at any level to be able to ask a really basic set of questions, even about their well-being, their safety, their functioning, their environment, we're so much better equipped to really assess that individual's needs and then get them connected to all the other services, either through Mary Center or in the community. So I'll be focusing on our school-based mental health program. We are a fairly young program. We're only in our 4th school year, and we started really by realizing there was a disparity in who was accessing mental health services at our outpatient clinic. It was a disparities conference. We realized there was a disparity in who was coming, who was showing up for appointments. At the time, there was a lot of media coverage about the statistics, which we all knew, that 1 in 5 children have a mental health disorder, often undiagnosed and untreated mental health disorder. In my opinion, in the community we serve, it can be a lot higher than 1 in 5 because of things like ACE exposure and trauma exposure. But yet we weren't seeing the clients come through the door. We would block off all of our afternoon appointments for intakes and services for children and families, and schools would refer tons of families for services. And families would come, they would participate in the intake, and then maybe start to miss every other appointment, or in a lot of cases, they would never even make it in the door for the initial intake. And so we realized that our access point, which at that point was only the clinic, was not accessible. And we all know the many barriers that low-income families face to accessing care, that non-English speaking populations face to accessing care, not the least of which is time, which is a resource that not all families have equal access to. So we decided, rather than waiting for the community to come access a service, which clearly they don't have equitable access to or face barriers to accessing, let's try bringing the service to the community. And so we began in a fairly ad hoc way reaching out to schools, because schools are where the majority of our kids spend most hours of the day, most days of the week, and put out a very basic needs assessment, asking questions like, do you feel like you were able to fully meet the mental health needs of your students? If not, would you be interested in exploring a partnership to have a therapist or provider come offer services on site? And the response we got was resounding, yes, we would love a partnership to have somebody come offer services on site. No, we do not feel like we can fully meet the mental health needs of our students. And by and large, in most of our schools, the population that they felt they had the least capacity to serve was in Spanish-speaking populations, was in recently arrived students, with unaccompanied minors. They would say, we know they have needs, we don't even know how to figure out what they are, let alone how to meet them. So since this is a clinical panel, I wanted to speak a little bit to the clinical impact of immigration. We get asked a lot, is there a magical screening tool that can tell us, how bad off somebody is, or what a child's needs is? And I really think we found that the best screening tool is just a good psychosocial evaluation of somebody's needs, and assessing not only for mental health concerns like depression, anxiety, developmental delays, ADHD, but family functioning, school functioning, home environment, and in kids who have been affected by immigration, who have experienced immigration, we really want to know, what was your experience of that like? Because we know there's no singular immigration story. We do a lot of group therapy for newcomer students, and we might have two youth that we assess from the same group, and one will say, my journey took 2 months. I was in the care of my 16-year-old sister. I was fainting because I was so dehydrated, and I was detained when I crossed the border. And another who says, I got on a plane, I was with my whole family and grandma. It took an hour and a half, and it hasn't been so bad. So we really want to know what was your experience of that like. And I won't go through all of these questions. These are all questions that we assess as part of our intake. And I really want to bring attention to the separation questions because they are so important. A lot of our kids are really dealing with separation and reunification on two fronts. They're confronting the reality of being reunified from their parent, in most cases, their parent or guardian, who they've been separated from for 5, 10, 15 years, and are dealing with the reality of reestablishing a parent-child dynamic after that long period of time. But they're also dealing with separation from the people who raised them. In a lot of times, cases that's a caregiver who they see as their major attachment figure in childhood. And another question we always ask is, why now? What was the impetus for you coming now? Or why did you bring your child over now? And a lot of times we hear either one or two things. Their caregiver passed away, their grandmother that was raising them got sick and died, or their PIA was murdered and we didn't have anyone else to care for them, in which case that child is in mourning, in addition to dealing with all of the other effects of the acculturation, of the immigration journey, of resettlement. They're in mourning. They're dealing with the loss of their parent, functionally speaking. Or the level of violence, the level of trauma escalated to where there was a threat, where there was something that happened in their home community, to where the parent said, I can't wait any longer, I have to bring them now. And we have kids who will say, I had 24, 48, 72 hours to pack my bag and leave. In which case, one of the questions we also want to get a sense of is, do you get a chance to say goodbye? And in a lot of cases, they didn't. Another domain that we want to bring attention to is why you, especially for kids who had long immigration journeys, did you eat? Did you sleep? We will have kids who come to us who are so malnourished, they're so frail when they get to us and they're falling asleep in class, and one of the first questions we'll ask is, have you been to a doctor? And if not, let's get you to a doctor or a nutritionist and get you back up to baseline before we can talk about therapy. So this is just a little bit about program considerations, regardless of your setting. I know we have people here from a lot of different settings, but in thinking about how do we make sure that the programs and services and systems that we're creating are really designed and prepared to meet the unique needs of the clients that we're working with. So first and foremost, what's your access point? We realized that our access point was not accessible for a lot of our families. And so simply by creating an additional access point of being the schools and of opening the doors to being able to meet and identify kids in that way, we were able to make the service so much more accessible to so many families. Last year, we served 650 clients and families in mental health services, and I would wager that 600 of those families never would have gotten services, never would have even gotten in the door, let alone gotten a full episode of care, had we just been in the clinic alone. So access is everything. Who is your client or patient, medical audience? Our client, in our case, might be the 5, 10, 15-year-old in front of us who is attending the school, whose health insurance we're billing, but we know that our ultimate client is always the family. We can treat the heck out of a child's depression, but we know that if there's no food in the home, if there's violence in the home, they don't have a home, we're not going to see a whole lot of improvement in that child's depression. So we want to, at every single step of the way, be bringing in the family in whatever way the child provides the family, to assess them, to give them access to resources. A lot of our parents are also dealing with trauma. A lot of our parents, we have whole family units that are active in fight or flight mode and are kind of in this constant state of hyperarousal. So all the work we can do to help stabilize and support the parents and the family is an ultimate investment in that child's well-being. And another note on that is that a lot of our kids are, like Diego, who Dr. Newman walked us through, a lot of our kids are placed in the care of somebody who's not a biological parent. We have kids who be in the care now of their sponsor, maybe their 18-year-old brother or their 25-year-old aunt. How prepared are those individuals to really take on the responsibility of having a child adolescent living in their home? There's emotional burden, the financial burden that we want to bring those folks into. How prepared are your systems to meet the unique needs of immigrant clients? In our case, we found that by being positioned in the schools, we have so much leverage. We have so much opportunity to really help shape the development of systems that are prepared to meet the needs of immigrant students, making school a safe, accessible, welcoming place for these students. around things even as basic as language access, as parent literacy level, making sure back to school nights are translators available for these parents. Building a trauma-informed school is a big part of what we do. If a child has gone through violent trauma, it's going to be very hard for them to read a required reading book in English or in history where there's violent trauma. So a lot of the work we do is in fact helping the school develop systems to really increase their capacity to serve these clients, which ultimately is to benefit to all students, not just immigrants. What barriers do you or your clients face, and how can you swim upstream of them? I know it's been a recurring theme today. One phenomenon we found in our first year in the school was that we were expecting, once we got there day one, to have this huge flood of referrals. And we got some, but then it would sort of plateau. And then December, January, we would get these floods of referrals for kids who were in active crisis. And most of those kids were Spanish-speaking students in their first or second year in the United States. And we have a lot of theories as to why that might be. For a lot of them, that was their first set of Christmas and New Year's in the United States. For some of them, that was the anniversary of their immigration. For some of them, they were just, when they arrived, really in a state of shock. And it wasn't until they were really able to get on their feet and they had the psychological capacity to move into the second and third stage of grief, which is depression, anger, which is usually when they get referred to therapy. But we found really it's problematic on two levels. Why are we waiting until kids are active crisis, until they were having a psychotic break, or they were self-harming, or they needed hospitalization, or they were getting expelled for disruptive behavior, to be concerned about that child? So figuring out how to support schools and proactively and preventatively identifying students of concern, doing things like universal screenings, knowing what red flags to look out for, building relationships with those parents, so parents that come in if they had concerns about their child. But the other thing we found is that a lot of those kids, when they got referred to us, didn't have health insurance. And in DC, we're so blessed to have universal coverage that any child or adult, as long as they're under the income threshold, is eligible for coverage for medical and mental health services. But yet families either were eligible but never knew, no one ever told them, or they found the process so daunting or so confusing or so intimidating, I find the process, all of those things, that they just never were able to prioritize that. So we figured out, how do we swim upstream of that? Who's the first person who has contact with these families when they arrive to the school? So we don't wait until they're in crisis and need acute medical or mental health services to figure out they don't have health insurance. We figured out our best allies in a lot of the schools were the main office staff, the front desk staff, receptionists, people who tend to be bilingual, people who tend to have really good working relationships with families, and a lot of schools, the first people who families interact with when they walk in the door. So we started meeting with them and saying, hey, how would you feel about having those brochures about, did you know you're eligible for health insurance? Do you know how to apply for public benefits? Do you have a doctor? If not, take this flyer. And it was working. But even then, we would find families were falling through the cracks, which in a lot of our schools of 1,500, 2,000 students happens. We figured out, even before they get to the school, who has contact with these families before their day one? We figured out that was the Language Acquisition Division, which is the office within DCPS who's responsible for testing and assessing students' ELL level and placing them in schools. So we swam a little further upstream and said, hey, Language Acquisition Division, would you be comfortable having this information in your office, asking these types of questions to families? And they said, absolutely. They asked if we could have somebody, one of our insurance specialists, come on site during their busy weeks before school began when they're doing a lot of enrollment to come meet with families directly and fill out applications directly. So we find that typically, even with the most complicated barriers, there's always solutions, and a lot of times they lie in really creative, unexpected, collaborative ways. And then lastly, the S word, what's your sustainability plan? I know this is a question that all of us are constantly having to ask and re-ask. In our case, we could not do this work without Medicaid. We are billing health insurance. We operate on a billable model. All the work, the preventative work on the front end to circulate, disseminate information about health insurance is part of our sustainability plan. We also invest really heavily in our relationships with schools and invest and take care of our partnerships because we see, obviously, our clients are our clients. We also see the school as our client. We see the partnership as our client. Because the more that we invest in those relationships and make sure that they are mutually beneficial, it's ultimately a long-term investment in the longevity and sustainability of our program. probably our biggest barrier that we face, and many of you may face the same challenge, is around how do we fund all this other non-billable work that we know is so crucial for supporting children and adolescents' well-being. Things like consultation and care coordination and care management and workshops and trainings, things that aren't billable to Medicaid but we know are so important. So what we're looking at is trying to figure out how do we blend public and private dollars to stretch the Medicaid as far as we can, so that we can supplement it with all this other work that we know is critical to providing services to these students and families. So these are some additional resources that we draw on a lot that are specific to providing mental health services in the context of the school. And I want to highlight the NCTSN, the National Child Traumatic Stress Network. A lot of their information is bilingual in English and Spanish, and it's excellent material to share with families, to share with partners, to share with other providers, no matter your capacity, to really inform our understanding of the impact of traumatic stress on child development. Thank you.
So we have time for a few questions, but I want to point out something. Rachel, your questionnaire that you showed us was very trauma informed. I mean, it's asking that essential question about what's happened to you as opposed to what's wrong with you. And that is so important when we think about, really trying to develop relationships and build the trust, which takes the time. It's not simply just giving a survey tool. And so I guess my first question I want to pose is to Jenny and to Dr. Newman with regard to that, because you both are talking about survey instruments, and you were very eloquent in speaking to the fact that you're pressed for time, which is really the antithesis of relationship building. So what has been your success in being able to get individuals to open up? And my other question is it really the physician that is in the best position to have that because of the press for time?
Well, we were very sensitive because we all have productivity requirements, and we want our provider to see 20 to 22 patients a day, and we didn't want to burden them. On the other hand, they want this information because they understand its connection to the health status of their patients. So we did work with our front desk in terms of distributing the questionnaires. We gave our medical assistants and the front desk scripts about how to talk to the parent or the teen about why we want these completed. We taught the medical assistants to score them so that time-consuming piece is done. We've also kind of given a script to the medical providers so that they can say to a parent or a teen, I'm so sorry this bad thing happened to you or these bad things happened to you. Nobody should ever have to experience XYZ. I have this person who I'd really like you to talk to, who would be just a great person for you to explore your feelings about some of these things that have happened. And the reason we say person and not therapist or social worker is that stigma goes up. I'm not crazy, I don't need it. And we try to get that therapist in there before the person can even say no. Just to do an introduction, what we call a warm handoff. And again, the medical provider has done the introduction and moved on. So we haven't gotten any pushback that it's taking too long because we're using the whole team.
Yeah, I would say that in DC, we're in a unique situation for a few reasons. Number one, that people have talked about the DC Healthcare Alliance and kind of the mirror Medicaid model for kids who otherwise have no access to healthcare. So we're very lucky in that everyone in DC should and can have healthcare. And the other part of our unique situation is that in DC, there's a requirement for an annual school physical, and kids are actually bringing healthcare documents to the school to present every year. And this year, there's even been more of kind of a push for vaccine requirements and holding those to accountability. So in a sense, we have kids and families who are obligated to come through our doors, and because of those requirements, we see a lot of people who are coming in for the formalities of that, and then we use that as kind of the entry point into branching out, providing other care. And I agree 100% in with your statement that we are absolutely not the best people to be handling all this, and unfortunately, it's come to us being the gatekeepers sometimes of being aware, first of all, that there are legal needs, there are mental health needs, and if you don't know what questions to think about and how to kind of inform yourself about patterns of things that you start to pick up on. You're not going to identify these needs, and I would echo exactly what you're saying, that the idea of co-located services is absolutely vital. I mean, if you have a mental health provider, a clinical psychologist, who you can knock on his door, in the office and go introduce your family that is already there, already taking off from their work where they're not getting benefits to be able to take off, and you can create a visit during that session, that is absolutely priceless. I mean, the chances once we have kids and families who leave our doorway of them coming back just for a mental health visit, the success rate goes way down. So if you can actually facilitate that during their medical care, it's a much better scenario.
We also have community health workers who help the whole range of other kinds of social service needs.
You're at time already, but if you wanted to stay for one or two really quick audience questions, we started late. Go ahead.
Are there any questions from the audience? Yes. I'm from the Office of Youth Responsibility in Baltimore, Maryland, and one of our challenges is finding ways to align, the approach to trauma-informed care with other communities outside the academic community. So the Latino community, I see in our department as a challenge. I work with faith-based coordination. That's one of the key places where people gather, in addition to schools and other doctor's offices. So have you integrated or have you found ways to include faith-based leadership and this outreach to the Latino community in regards to trauma-informed care?
We have not stepped into that journey yet, although I can see it being valuable.
I don't know that I can speak a more general answer, but just generally figuring out what are the natural, intuitive, organic places that these families already relate to and kind of center around. We always ask questions like, we know one of the most predictive factors to help explain somebody's level of stability is, do you have a place where you feel supported, a home, a community center, a church, and really work to strengthen individuals' connection to that. So it's not directly answering your question, but I think you're asking questions along the right lines of where families are already connected to, and using those outlets when we know that a lot of families maybe won't foray into the public mental health system because of the stigma, but there's just places where they won't naturally go, tapping into where they already are, like schools in our case.
So I can say from one of the partner networks to the Building Community Resilience Collaborative is actually reaching out to sanctuary churches in I believe it's in Portland and in Seattle. And so that's a way for them to really just become a part of the community first before having that clinical interaction. And so it's developing the relationship with where we know as a sanction, where it's a haven for families and community, and developing it there before they move them into the clinical environment. And that's been really successful in the sense that that is the first place of trust and relationship building, and kind of developing what we've been getting to call it sort of a maven network. So there's always someone in the community that knows everyone and is really more comfortable in connecting outside of the circle. And so if you have that person acting as an ambassador to more of the health system or the social service network, that's sort of the way that they've been going. We have a question in the back.
Yeah, my question is, my name is Juan Pacheco, and I would just like to say the comment that I think it's important to look also backwards and deeper in terms of the trauma that young people are experiencing with this new wave of immigration, right? So new wave of immigration that the young people were experiencing in the schools, in our systems, in our communities, is not an isolated thing that just spurted out, right? I'm actually one of the first young people who experienced that trauma in the 80s when Mary Center was built, when Central Americans were escaping, Central American Civil War. And so I would ask you that to kind of think about the idea, right, of connecting this trauma-informed care to actual culturally sensitive and aware trauma-informed care, right? So for example, I would venture to say that in El Salvador, mental health is actually something that we do have, but it doesn't happen in the context of clinical care, right? So for example, the viejos, right, the elders, the men in my community, the way they did primary mental health was at the esquina, at the corner, right? And that's where they talked, and I would venture to say that that was our social cycle developmental group, right? And so how do we create that culturally relevant esquina in a place like DC, right? And so I would say that it takes going deeper, understanding the root of how we see mental health happens in our communities, utilizing native, ways of doing it in our culture, and also looking back, right? In terms of that, the knowledge that you were seeking about medicine was in DC. It was just in the doctors and the nurses and the school folks that dealt with the same issue in the 80s, right? So I think that's also important to deal with what the young people are going through now in terms of their traumas.
So I'll let you take one more question, one more short question, one more short answer.
I just want to follow up with what you're saying, because it is so fundamentally true in the trauma-informed circle, and it's one of the things that we're learning is that it's not always a prescription for healing, but in the sense that it's coming from a doctor's pad. We've seen in communities where we've started using healing circles, so there's drumming circles for the African communities, where they're using the promotoras in the Latino communities to do more of the traditional healing practices. So it's not always Zola. It may be something that's really culturally relevant, but it also helps to build community. And that's really, at the end of the day, it's going to be about the strength of the community to support those individuals in the healing process from their trauma. So thank you for saying that. So one quick question,
One more quick question, one more quick answer.
oh yes, I'm sorry.
I'm a Pennsylvania area free clinic, and we're a primary care provider in Pennsylvania County in Northern Virginia. And while we see many of the cases like the children that you presented here, we also have a growing population of young adults who are starting families and are still suffering from trauma and bringing their families into that trauma. So I guess my question is, how do the interventions change when we're looking at young adults and adults starting families? Because there's a physiological response on the moms with the baby removed, that changes hormones, but there's also how do we stop these ACEs from appearing within their own families as they become established and have children born here? So where do the interventions change, or do they?
Well, I think we have to understand what impact the trauma has on the individual, right? So if the individual is having a certain set of symptoms, we have to find an intervention that addresses those symptoms. If it's anxiety, if it's depression, if it's self-esteem, if it's reparenting in an aggressive way, maybe in terms of how they were parented. I think there's a room for an evidence-based intervention that addresses the anxiety and the depression, but there's also a lot of psychosocial education that needs to happen. And I don't think it all has to be clinical. I mean, there's a lot of discussion in the trauma work about the needs for helping people learn just how to self-soothe, meditation, yoga, things that might be culturally appropriate in terms of getting together with friends and cooking or music. That isn't just a clinical intervention. I don't know that there's a clear answer to that. I think it's really critical that we understand the impact of ACEs on everybody, not just children, but adults as well, and that we screen and have those conversations about trauma so that with the client, we can figure out together what's going to work best for them.